Hello everyone, and welcome to this audio podcast. This audio podcast is part of the conglomerate. This audio podcast is as part of a Lobostic Shy Storm. This audio podcast is as part of a Storm and Battle and Chronicle. This audio podcast is part of the Stormish edition or series, and this audio podcast is part of a Storm Lobostics production. Through this audio podcast, I look at an overview of focal segmental glomerulosclerosis. In this overview, there will be a look at a look at focal segmental glomerulosclerosis or FSGS classification. A look at primary FSGS, a look at adaptive FSGS, a look at genetic FSGS, a look at virus-associated FSGS, a look at medication-associated or pharmacotherapeutic-associated FSGS, a look at sort of the signs and symptoms of FSGS, a look at diagnoses of FSGS, a look at sort of therapeutic or pharmacotherapeutic approaches. I look at FSGS, and FSGS associated UTI, and acute pyelonephritis, scarring or tract scarring. I look at I look at sort of tract scarring and FSGS, aligned with our vesico-urethral reflux or VUR, and then I look at in around FSGS and sort of risk factors for scarring or tract scarring, and then look at an overview in as part of the pediatrics or young population where FSGS is or has been in amongst the literature as a sort of a population sort of predisposed to FSGS, and then this audio podcast, there will be a summary. So to begin with some intro, focal segmental sclerosis or FSGS. So glomerulosclerosis refers to scarring scarring or hardening of glomeruli. FSGS is a type or a form of glomerular disease or condition, and relates scarring or sclerosis across renal pathophysiology. The scarring of FSGS only takes place in small sections or small parts of each glomeruli. It is the most challenging and enigmatic of renal sort of conditions or diseases. It can occur as a primary disorder without an identifiable cause, or as an illness or condition secondary to a variety of primary sort of comorbidities. It is one of the most important causes of acquired CKD in pediatrics or young people and in adults. FSGS can reoccur in around 20 to 25% of the solid organ transplanted recipients. Males are FSGS males affects in such a way where there's slightly more predominance than in females. It occurs more frequently in amongst at least where literature has informed in amongst African Americans. FSGS is not caused by a single disease or condition. The scarring or tract scarring can happen because of infection or pharmacotherapeutics or a condition that affects the entire body. So, for example, human immunodeficiency virus, sickle cell disease, or sickle cell anemia, or lupus, or lupus. FSGS can also be a sort of predisposition for nephrotic syndrome. So as part of FSGS classification, so there's primary sort of idiopathic, primary idiopathic, and then secondary form of FSGS. In amongst primary idiopathic FSGS, it is where primary idiopathic or idiopathic FSGS is a sort of a predisposition for predisposition, or as a cause based on primary conditions, primary healthcare conditions. For example, the secondary form of FSGS is and can be a virus associated form, pharmacotherapeutic induced form, and a genetic form. In around primary FSGS, the mechanistics of polycyte injury involves a circulating factor cytokine, a cytokine that makes particular recipients susceptible. The most common form in adolescents and young is one of the most common forms in adolescents and young people and young adults. Commonly associated FSGS or primary FSGS is commonly associated with nephrotic range in around the nephrotic range for particular and specific biochemistry laboratory parameters, and where there can be reduced plasma albumin levels, histologically, primary FSGS, histologically, it may manifest as the top or the tip of as the tip sort of the tip variant collapsing as the tip variant and collapsing variant, and or NOS variant. Currently, or in amongst the literature, pharmacotherapeutics are on the basis of immunosuppressive agents or ISTs, including corticosteroids, and or calcineurin inhibitors. Excuse me. Pharmacotherapeutics with for example, plasma exchange may induce a remission. Now, looking at sort of adaptive FSGS, FSGS as part of the adaptive arises after a duration of nephron level glomerular hyperfiltration, glomerular anomalies anomalies in around ABP, arterial blood pressure, and increased single nephron GFR, leading to progressive cycles of glomerular hypertrophy or inflammation of renal kidney parenchyma, podocyte hypertrophy, and stress and stress stress in around the renal parenchyma. Total GFR can be elevated, normal, or decreased at the outset. It is associated with an increase in total GFR, which includes a congenital cyanotic cardiac or myocardium abnormalities, sickle cell anemia, androgen abuse, sleep apnea, and in amongst some additional abnormalities, in addition to some other primary abnormalities. The duration of single nephron glomerular hyperfiltration is typically analyzed through laboratory investigations, and renal biopsy, for example, features that are useful that support diagnosis of adaptive FSGS include large glomeruli. Clinical features include a normal serum albumin, which is unusual in primary FSGS. The number of genes associated with FSGS rises annually. Some genes are associated with a syndrome that includes external manifestations, and this can provide a clinical clue that recipients might have a form of FSGS mutation amongst a particular gene. Some genes are associated with characteristic changes in basement membrane morphology or mitochondrial morphology. Every family with a child or young person diagnosed with FSGS should be offered genetic screening. Pharmacotherapeutics for genetic FSGS is generally conservative and on the basis of renin-angiotensin aldosterone system. Excuse me. And calcineurin inhibitors may have an effect in a minority of recipients. Coenzyme Q10 can be advantageous. Literature has evidence amongst individuals with mutations in certain mitochondrial defects. Now looking at sort of the virus-associated FSGS. So HIV1 is strongly associated with FSGS. Other viruses that have been associated with FSGS include cytomegalovirus, parvovirus, B19, and Epstein-Barr virus, Epstein-Barr virus, or EBV. Certain parasites have also been associated with FSGS, presumably by stimulating innate immune pathways. These include Plasmodium falciparum, in regard to malaria, schistosoma mansoni, and filariasis. The mechanistics likely involve direct infection of podocytes. Now looking at sort of medicine or pharmacotherapeutic associated FSGS. So interferon therapy or pharmacotherapeutics have been associated with the development of collapsing glomerulopathy. Bisphosphonates are associated with podocyte injury. Sirolimus being a form of IST or immunosuppression, has been associated with FSGS when plasma levels are high. Anthracycline pharmacotherapeutics, including doxorubicin and donomycin, have been associated with FSGS. In around FSGS signs and symptoms, early stages may not cause any symptoms. Swelling in body parts such as legs, ankles, and around the eyes, is and can be forms of signs and symptoms. Additional fluid building in amongst pathophysiology compartments can be a sort of where signs and symptoms for FSGS occur or are evident. Foamy urine caused by abnormal biochemistry parameters can be linked to signs and symptoms of FSGS. Low levels or abnormal levels of particular biochemistry parameters at the same time in the blood can be signs and symptoms for FSGS. Also, fatigue, poor appetite or headache, itchy skin, shortness of breath, and nausea also can be signs and symptoms for FSGS. And around the diagnosis, it has been based on the detection of segmental sclerosis and hyalinization of a portion of the glomerular tuft, wherein through FSGS diagnosis, there is where clinicians look to attain a clinical history, a look in on laboratory findings or analysis, and in around sort of biopsy findings. So in around relevant clinical history, family history of renal disease is important. Birth weight, sickle cell anemia, history consistent with reflux nephropathy, or reduced renal mass, i.e., wherein the renal parenchyma is affected, where the infrastructure sort of compromises the kidneys in such a way that the renal mass is affected. And then in around a viral as part of clinical history of viral infection is and can be helpful. In line to pharmacotherapeutics as part of clinical history, pharmacotherapeutics wherein there are pharmacotherapeutics with a sort of constituents or components of interferon, lithium, bisphosphonate, nephrotoxic pharmacotherapeutics. And as part of laboratory findings, serum albumin before the use of any pharmacotherapeutics is and can be useful. Change in creatinine ratio after renin angiotensin aldosterone pharmacotherapeutic is and can be helpful. Change to creatinine ratio after immunosuppression or IST pharmacotherapeutics is and can be important as part of laboratory analysis and blood investigations. Blood investigations as part of laboratory analysis can be helpful. As part of therapeutic approaches, pharmacotherapeutic approaches, pharmacotherapeutics should be individualized on the basis of particular forms of FSGS as well as factors particular to recipients. FSGS may be responsive to pharmacotherapeutics with corticosteroids, although relapses are typical or can be typical. Pharmacotherapeutic associated FSGS can be managed by stopping or precluding the offending pharmacotherapeutic and virus-associated FSGS, which can be treated by initiating antiviral treatments. Treatments for FSGS in amongst literature have included corticosteroids, immunosuppression, plasmapheresis, ACE inhibitors, and ARBs, and diuretics. In amongst a UTI and acute pyelonephritis and scarring in around FSGS. So acute pyelonephritis in children and young people can lead to scarring. And wherein acute renal parenchymal damage and subsequent where subsequent soil abnormality leads to permanent UTI or APN scarring or tract scarring where FSGS is concerned. Extensive scarring in recipients progress to renal injury with a subsequent decrease in renal function and leading into ESKD or ESRD. Permanent renal scarring has been observed in amongst literature in 15% to 60% of affected children or young people where FSGS in around FSGS recipients. Acute inflammatory response eradicate the invading bacteria and is responsible. So acute inflammatory response is and can be important for early renal parenchymal prevention of renal parenchymal damage and subsequent scarring where FSGS is concerned. In VUR, vesicourethral reflux and scarring, and as part of FSGS. The role of scar formation is significantly higher in children, in infants, children, young people with VUR, with vesicourethral reflux than in those without, where FSGS is concerned. The incidence of renal scar formation was significantly or has been significantly correlated in amongst literature with VUR grading. VUR severity was or has been significantly associated with the risk of with the risk of permanent renal parenchymal abnormalities. VUR increases the risk of renal scar formation post urinary tract infections or UTIs, UTI scarring, and at the same time, VUR is perhaps one of the most important risk factors for the development of post pyelonephritic renal scars in FSGS recipients. Risk factors for some risk factors then for scarring. So vesico-urethral reflux is one of the is a main risk factor for renal tract scarring. Bacterial virulence, host defense factors, genetic susceptibility, APN, acute pyelonephritis, hydronephrosis, and urinary tract infections. In amongst the pediatrics and young people population specifically, those with an increased level, those where there is increased levels of procalcitonin, children and young people which have high sensitivity in identifying with severe reflux. Those with high fever who are younger than 6 months of age, recurrent UTI, clinical signs such as poor urinary stream or palpable renal pathophysiology, and infections with atypical organisms, and bacteremia or septicemia. That is to say, where bacteremia wherein hematology and within in amongst hematology and amongst the as part of urinalysis, bacteria or specific microorganisms are identifiable, and septicemia being where the blood or hematology is affected. So in summary, FSGS is a chronic sort of condition. The scarred glomeruli cannot be repaired. Pharmacotherapeutics can slow progression. Every recipient responds different to treatment. Some recipients with FSGS gradually get worse until they reach end stage ESRD or ESKD. Some recipients respond well to pharmacotherapeutics and may live with the condition with FSGS for many years, while being monitored for any signs and sort of changes. That draws this audio podcast to a close. This audio podcast is part of the conglomerate. This audio podcast is part of a Lobostics Shystorm. This audio podcast is part of a Storm and Battle and Chronicle. This audio podcast as part of the Ztormish edition or series, and this audio podcast as part of a Storm Lobostics production.